seem a long way away. Yeah. Always happens, doesn't it? Who knows about MSA from a personal perspective? Yeah? And the rest of you are just here so you can understand a little bit more about it. Is that right? Well, and just like I started the last talk where they asked me to talk about dementia, talking about multiple system atrophy is also, I find, difficult because it's another one of the neurological syndromes that we have no treatments for, none. So it's a little bit on the depressing side, and I apologise in the advance, but it's also an area of research which is actually, for a while there, hardly anybody did any research on it, and there's been an enormous amount of research on it more recently, because it actually has, in common with Parkinson's disease, alpha-synuclein deposits in the brain. And so because of that, lots of drug companies are actually really interested, because as a disease it doesn't have a treatment, and therefore they can do a lot more clinical trials on patients because there's nothing, and so they can investigate a lot more further on patients with multiple system atrophy. The other thing is, because it doesn't have any treatments, it often has a much more rapid disease course. So for those two reasons, they can see if a drug has an effect more rapidly, and also it doesn't have treatments. So those are some things that you've just learnt, the difference. There's treatments for Parkinson's disease. And I'll now tell you a little bit more about both the symptoms and the underlying pathology. And then at the end I'll spend about half the talk on the new research, so where the research is heading and what we now know, and even all the drugs that are now being tested in patients. So first off, multiple system atrophy and Parkinson's disease are similar in that they both have the alpha-synuclein protein depositing in the brain, therefore they're called alpha-synucleinopathies. Now, alpha-synuclein is something we find normally in everybody. In fact, if you don't have alpha-synuclein, you'll be in trouble, because it's a protein that's really important for actually making sure that the synapses work appropriately, and the synapses are important for one brain cell to speak to another brain cell. So you can't transmit any information without having alpha-synuclein. So it's a normal protein. It's actually quite a protein in high abundance because your brain works by transmitting information between neurons, and so it's actually one of the high abundant proteins in your brain. There's it's one of the few proteins that doesn't actually aggregate abnormally with age per se. It's actually a disease-specific aggregation. You'll be very unhappy to hear this next thing I'm going to tell you, but there's two age-related proteins that aggregate very readily that actually cause Alzheimer's disease, the A-beta protein and the tau protein. And 50% of the population has some tau aggregating in the brain by the time you're 50. So most of us in the room would have some tau aggregating in our brain. It's the amount of tau and where it aggregates that's important. And 50% of the population have A-beta aggregating in the brain by the time you're 70. So these are actually age-related proteins that can aggregate in everybody, aggregate quite readily in the population, and if you get enough of it in the wrong places, you will actually get Alzheimer's disease. Alpha-synuclein is not like that. It only aggregates in diseases. So there's a number of diseases it aggregates in: multiple system atrophy, Parkinson's with dementia, and dementia with Lewy bodies. And those, and they now know it also aggregates in REM sleep behaviour disorder, and not much else. So those are the diseases that it aggregates in. So they have synuclein. What's the difference? The main difference is, actually, there's some things that aren't different. There's two main phenotypes, clinical phenotypes for multiple system atrophy, and one of them can overlap quite a lot with Parkinson's disease. It has Parkinsonism and it has REM sleep behaviour disorder. And that's very similar to many patients that might have Parkinson's disease. And in fact, many of those patients also have levodopa treatment that is effective at least for a short while. And that's because they look like Parkinson's, they maybe have a problem in their dopamine system, and they have alpha-synuclein. The ones that don't look so much like Parkinson's particularly have gait impairment, ataxias, limb and eye saccade problems, so they have trouble with their vision, they have trouble walking straight lines particularly, and can be thought of as more of a drunk-like gait, and also problems with smooth movements of the limb. And many of them also will have autonomic dysfunction, like problems with the bladder, problems breathing, particularly with the voice box becoming very restricted, so it's like you can't get enough breath in. And they have a problem with swallowing, so they have a lot of dysfunction of the autonomic nervous system. So there's some that actually can look very similar to Parkinson's and some that actually look very different from Parkinson's. And interestingly, they'll all have the same underlying pathology, but in different parts of the brain. Now, I've just put up here the average diagnoses and what happens in a patient that would have Parkinson's versus multiple system atrophy. In general, it's around the same age at onset, but you get a much shorter, more rapid duration in multiple system atrophy than you do in patients with Parkinson's disease, and a lot more problems with likelihood of wheelchair dependency very quickly. So as I said, it's a more rapid disease and robs people of their movements and functions quicker. If we look at how that relates to the underlying parts of the brain that are affected, there's more parts of the brain that are affected in multiple system atrophy. So in addition to the dopamine system, all the areas that the dopamine system projects to are also affected in multiple system atrophy. When I say affected, it's not just a problem with the alpha-synuclein actually depositing, but they actually get neuronal loss. So there's a much more widespread loss of the neurons in the brain in patients with multiple system atrophy. So in the pathology, the synuclein pathology is not fast at all in patients with Parkinson's disease. It's much more rapid in this multiple system atrophy. And the difference between the two types of multiple system atrophy is just where in the brain the effects are being felt. So the type that has the problem with walking actually has a lot of more on the lower brainstem and the place called the cerebellum, which is affected. And whereas the Parkinson's patients mainly have it in the brainstem to start before it goes into cortical regions as well. So they have slightly different regions of the brain that are affected, but much more of the brain is affected early in patients with multiple system atrophy. This is a Lewy body in a cell from a patient who died with Parkinson's disease, and these are glial cells in patients with multiple system atrophy because the pathology actually deposits in the glial cells and not the neurons. And the glial cells that it deposits in are a specific type of glial cell. They're called oligodendroglia, and they're the insulating cells in the brain. So every axon from every neuron is wrapped by oligodendroglia, and you need that the more oligodendroglia wrapping you have, the faster the connection, the faster the information you can get from one place in your brain to the other. So the cells that are primarily affected with the pathology are the glial cells in multiple system atrophy, and that means that the connections between the cells are affected and the cells themselves die. So if you take away the oligodendrocytes, then they're not wrapping the axons, then the axons are more exposed. It's like having electrical wiring that doesn't have insulation. It's more likely to have a problem with the actual connectivity, but eventually it actually affects the electrical conductance of the equipment itself. And there's another difference between the two. The actual type of fibril is actually quite a little different. Now, you might not be able to see it, but these are examples of the fibrils, and they actually are slightly different between Parkinson's disease and multiple system atrophy. So they're not exactly the same form of alpha-synuclein that's depositing, so it's not the same cells that are actually getting it, and it's not the same form of the protein, so the abnormality in the protein is different. The protein in Parkinson's disease is really resistant to being broken down by anything, whereas the protein in multiple system atrophy can be broken down by enzymes that are in your tissues, even though it doesn't look like it, but it does actually, it is able to be gotten rid of more. So I told you about the oligodendroglea, and they're the ones that have the majority of the protein is depositing in oligodendroglea, but there are some abnormalities in neurons, and neurons are not spared, but there's less abnormalities in neurons than there is in oligodendroglea. And this is just to show the structures. These types of papers are published in really high impact publications. They mean very little probably to most of us, which is fine. All they do is they show that the molecules themselves can aggregate in different ways. And you think, well, why is that important? But if you're going to actually build something that might actually affect it, having knowledge that the protein is slightly different means that the way you would attack it to get an aggregate changed would actually be different. It's a bit like saying, I've got a beam that's a bit crooked versus a beam that's straight. And therefore, if you're wanting to get the beam straight, or if you want to get rid of both beams, you might actually use a different kind of tool because of the way the beams are actually constructed. So this actually, even though it feels meaningless, even to me, it's actually important for therapeutics to actually affect the proteins themselves. The thing that happens with the cells, so these are the oligodendroglea, not only do they actually aggregate the protein, but they aggregate all the other types of proteins that normally make them function, which means that the cells not only have a big lump of synuclein, but they completely lose the main function that they have in the body. And the cells themselves enlarge, so they get much bigger. So these cells have these insulating specific insulating processes that they grow as a specific tool so that they can insulate the axons. And then what happens is all those proteins build up in the cell body, and it's like the cell itself, it's like having a dress and you get rid of the skirt. They actually just get rid of that part of the actual cell and become a completely different type of cell. They don't die, which is really interesting. So they live with these aggregations and they change their function and they no longer insulate the axons. So what I've told you is that there is some overlap and there's some differences. So the difference with Parkinson's disease is that they maintain a reasonably good and sustained response to treatment over time. That they and that there's a proportion of people with multiple system atrophy that can look very similar to patients with Parkinson's disease, even having some response for the early years. And then some people with multiple system atrophy will look quite different, where they have more gait involvement, more respiratory problems, and particularly around the voice box and the upper gastrointestinal tract. They have quite different pathologies. The Parkinson's disease have those inclusions we call Lewy pathologies, clumps of alpha-synuclein. They're mainly in neurons. They don't affect the glia, and particularly not the oligodendroglia. Both types of multiple system atrophy have a prominent oligodendroglia problem where they actually get synuclein inclusions, and the actual oligodendroglia change completely their function. All of these will have dopamine cell loss, and the multiple system atrophy have quite a number of other neurons that are also degenerating in the brain, so much more widespread neuronal degeneration without significant neuronal inclusions. They talked a lot about genetics for Parkinson's disease. I haven't put a slide in, but there is no known genetic influence on multiple system atrophy. So in all the genetics that people have looked at, there's nothing that's in common that's significant at the moment for multiple system atrophy. So now I wanted to just go through what the research now that's happening in multiple system atrophy is, and there's actually quite a lot of it, as I told you, and so the next half of the talk is actually what's coming down the pipeline and what we're now understanding a bit more. So because it's a more rapid disease and because it has that overlap with Parkinson's and can be actually misdiagnosed, early diagnosis is one of the biggest things that is actually trying to be researched in multiple system atrophy, to be certain that we know that it's actually this disease and not Parkinson's disease. And I told you that they have a gait problem. There's other diseases that also have gait problem that are not multiple system atrophy, so diagnosing synucleinopathy with a gait problem is quite different to some others. So early diagnosis is something that everyone is spending really a lot of time with. So there's new research that's shown that you can look at brainstem, some imaging, and actually make some measurements based on the structure, how big the structures are in the brainstem, and that and in association with if patients have started to snore, because as I said, there's a problem with the voice box and getting breathing a lot. So changes in the brainstem and snoring are actually good indications that will differentiate multiple system atrophy from other types of problems that are to do with gait and Parkinsonism.
Excuse me. Does snoring in multiple system atrophy benefit from CPAP?
It would, because they have just general autonomic problems. So their whole CPAP is generally used because you actually have a floppy, whereas this is actually more restricted, but it probably would benefit. It's a good diagnosis, but yeah, okay. The person who would work on respiratory medicine would know more. But CPAP usually is used for a floppy, like a floppy esophagus rather than a tight. This snoring is actually because they actually have a restricted tight esophagus. So there's other imaging techniques. The oligodendroglia are the cells that actually insulate the axons, and the axons go through, on the images, through what they call the white matter, which is all the white substance you see when you actually are looking in the brain with an imaging technique. You see white matter and grey matter. And so they have now looked to see if they can see the loss of the white matter, which is where the oligodendrocytes would be insulating, and they can actually detect changes in the white matter, and they correlate with the severity of the symptoms in patients with multiple system atrophy. So it's not only a good technique to see is the white matter, is the oligodendrocytes affected, but you can see over time the tracking this could tell you, predict what might be coming because it's a sign of progression. And because there's no therapy or anything, they're testing new alpha-synuclein imaging ligands. So there's PET imaging ligands for Alzheimer pathologies, the A-beta and the tau. And so you can, in Australia, I don't know about here, you can get an image of the brain to see if you've got amyloid depositing or if you've got tau depositing. And they're starting now, in fact, the only ones that they're actually now starting to look at it in multiple system atrophy. You can, in multiple system atrophy, the new ligands look like they're effective, and that's probably because of the amount of pathology. And unfortunately, they're less effective for Parkinson's disease or dementia with Lewy bodies than they are for multiple system atrophy. And it's probably just to do with the amount of pathology in multiple system atrophy compared to the other alpha-synucleinopathies. But it's one of the first synucleinopathies where they might have a ligand that specifically sees synuclein depositing. And they have other biomarkers. So this is now looking at the level of a blood serum and looking at urate, which is something that is produced by your liver. And they've been able to say that the amount of urate in the blood, if it's high, it's protective, you have less white matter problem, and if it's lower, you have more white matter degeneration. So they think that they can also use a blood, looking at blood, urate quantity may actually also help in identifying how fast or rapid the disease may be progressing in a person. Excuse me. They're also looking at other forms of alpha-synuclein. Alpha-synuclein not only has a structural change to the fibrils are actually physically changed to make the clumps, but the material, this protein also has what they call post-translational modifications. There's lots of enzymes that try to change the protein so that it will work properly or it will stop clumping or whatever. And phosphorylation is one of the things that actually helps the protein to fall on and off membranes. So it's a normal functioning that the protein has, and if you have too much phosphorylation, it doesn't stick to the membrane of the cell that it should be working on, it sticks to itself instead. So phosphorylation makes the protein more sticky. So they're now looking at phosphorylated alpha-synuclein, and they can actually look at the cerebrospinal fluid, which I think we talked about before, and if you've got a high amount of phosphorylated alpha-synuclein in the cerebrospinal fluid, it seems to differentiate multiple system atrophy from other synucleinopathies. So it's another potential way of seeing if it's which of the synucleinopathies it is. And then there's also looking at alpha-synuclein in association with neurofilament light. Now, neurofilament light is a protein that actually makes the skeleton of the axons. So to actually have a good axon, it's like a copper wire. The neurofilaments are actually lined up so that the axon has a good structure. So they use neurofilament light chain as a indicator of how much axons are being degenerated. If you've got a lot of neurofilament light in a peripheral tissue, it's not in your axon. It's somewhere it shouldn't be. So this is looking at cerebrospinal fluid for neurofilament light, as well as for alpha-synuclein aggregates. And they are looking to see whether or not it can differentiate early multiple system atrophy and patients with Lewy body diseases. And it has a higher amount of neurofilament light and aggregates in the CSF differentiate MSA. They have earlier aggregation, and they have lower, you can see the discovery cohort with higher neurofilament light, confirmation of the cohort. You can see the neurofilament light is very affected in multiple system atrophy and hardly affected at all in Parkinson's disease and dementia with Lewy bodies. So in association with aggregated alpha-synuclein, this will be a potential test to differentiate multiple system atrophy in the cerebrospinal fluid. And then there's some new blood tests that they're looking at. So they are really looking hard to see what's going to actually be most effective. These are called blood exosomes. Now, every cell you have in your body also not only communicates with other cells by making small vesicles and sending information through that mechanism. So the little kind of vesicle bugs that come off cells, every cell does it, including neurons and glia. And so you can actually then look in the blood for specific little exosomes, these little vesicles that are made by particular cells. And so they're looking in the blood, in this instance, for vesicles that are made by neurons or oligodendroglia. And so they can see how many of the vesicles are coming from both those types of cells, and they can distinguish whether or not you have Parkinson's or multiple system atrophy, because you'll have less vesicles from your oligodendroglia in multiple system atrophy, or more that actually have synuclein in them, and you'll have less vesicles from neurons because there's more neurons die in multiple system atrophy than you would have from Parkinson's disease. So they can take the vesicles, identify them, and then actually look to see what their contents are, differentiate between multiple system atrophy and Parkinson's disease. And that's from blood. So in addition to lots of ways that people are trying to actually make sure they can diagnose the disease as early as possible, they're also trying to understand potential causes of the disease and what might be happening in the tissue. And they're actually looking at blood cells in this particular one, and they've looked at a type of blood cell that you get in your blood called the monocyte. It's one of your white blood cells. It's really important for immune function, like if you actually have a pathogen, that a virus or bacteria or anything that gets into your blood, these are the white cells that are actually sent to get rid of it. So these monocytes seem to be changing in multiple system atrophy, and there's a change in the brain to attract the monocytes into the brain, suggesting that there's an immune response that's happening in the brain itself that will attract these white cells to get rid of something that's in the brain. So they think that there's a neuroimmune response that's specific to multiple system atrophy. This is not a response we see in Parkinson's disease, for example, and so it's not to do with the synuclein itself, it's to do with specifically with multiple system atrophy. It's one of the diseases because that we hadn't had any animal models for. There's actually quite a number of models for Parkinson's disease. I don't know if you knew, but the most commonly used models for Parkinson's disease are pesticides. They inject animals with pesticides and that gives the animals Parkinson's disease. Or they give them a gene mutation and that gives the animals Parkinson's disease, alpha-synuclein. But what it does is it doesn't give none of that gives anybody, any animal, multiple system atrophy. So there has been no way of looking in an animal model as to potentially why this would happen. And that's because we don't understand the cause, but anything we've been trying gives Parkinson's disease models and not multiple system atrophy models. So now what they've done is they've actually injected rodents and non-human primates now with, they've packaged the alpha-synuclein into a normal virus that can't replicate. and then they've injected into the brain so that it only goes to the oligodendroglia. So now they're putting alpha-synuclein, abnormal alpha-synuclein, into oligodendroglia, and that gives them models now for multiple system atrophy. So they're a novel construct that only infects oligodendroglia, and when they inject them into the regions that are affected in multiple system atrophy, they get models that are really quite the same. So these are new models, so now that they can actually use animals more readily to actually test a variety of treatments, because before we had no way of modelling the disease itself. So no, it's AAV virus and adeno, which is they're viruses that are much more brain specific. So that's been relatively new. I think it was late in 2021, and so now lots of drugs that probably weren't effective on Parkinson's disease, or if they even were, can actually now be trialled to see if they can have an effect on the new animal models they've got of the disease. Will it stop anything to do with the degeneration and the synuclein deposition in the oligodendroglia? Now, I'm going to talk a little bit about potential treatments, and as I said before, there's a lot of work in this area, but there's no good news really yet. But there is some small trials of rehabilitation, and they've been effective at alleviating the symptoms. They don't stop the disease, but they change the symptoms. A 5-day inpatient physiotherapy program, followed by 5-week unsupervised home-based exercise, showed improvements in gait performance. And they were sustained improvements, but not hasn't been no further follow-up at this stage. And physical rehabilitation in hospital using a variety of physical occupation and speech therapy showed significant improvement in a variety of the actual symptoms that these patients have. Unfortunately, none of these actually improve the emotional health, and that's one of the things that's actually really problematic in patients with multiple system atrophy from a perspective of the brain regions that are affected, as well as from the rapidity and the variety of symptoms that they have. So this has promise, I think, to actually at least have some effect on symptoms, which at the moment there's very little drug therapies that actually are symptomatic.
Any suggestion that exercise and rehab are disease modifying in the same way that there are suggestions in Parkinson's that there are?
Sorry, I missed the first bit.
That exercise and rehabilitation might be disease modifying and...
I doubt it, because it's very fast. I mean, it could be. The glia are one of the cells that actually makes the growth factors that are for your neurons. Your neurons don't make a lot of growth factors. Because this is actually affecting the glia themselves, and these glia actually wrap every bit of your neuron. I'm not sure whether or not you'll actually make a difference to the glia because of the type of cell. But who would know? You know,
Yeah.
who would know? So I think it might be symptomatic rather than disease modifying, which is different to Parkinson's. So this is April 2024. It's a picture which shows the type. We're talking about neurons, we're talking about oligodendroglia, we're talking about microglia are like the monocytes of the brain. So if you've got an infection or anything, they're the ones that are actually, they're literally from a monocyte-like cell in the brain. And in all of these different places, there are drugs that are being tested now in patients with multiple system atrophy. So they're looking at messenger RNA with this drug, and they're looking at alpha-synuclein directly with this drug. They're looking at how you can, an enzyme modifier for alpha-synuclein with this drug, immune therapies with those drugs, mitochondria dysfunction. They're looking for neurotrophic support because the glia are affected. They're trying to get aggregation inhibitors in, clearance enhancers. All of these are happening in trial right now in patients with multiple system atrophy. And this isn't that's just current trials, which is a lot. Lots of different ways they're thinking about it. But there's also trials that have actually started and nearly completed. There's active immunotherapies that were vaccinating people against alpha-synuclein. They had a phase 1 and they were well tolerated, which means they'll go through to the next phase. And one of the vaccines produced a rapid and long-lasting antibody response. So they're really hopeful that that may actually go on. Hate to tell you, but the antibody vaccinations in Parkinson's disease have not proven successful, but it might prove successful in multiple system atrophy. And that might be because there's more of an immune response and you vaccinate because of an immune difficulty. It could actually have more effect in this than it does in Parkinson's. They noticed that vitamin B12 was associated with shorter survival in patients with multiple system atrophy, and they think that may be amenable to modification. They're now starting vitamin therapy to see if that will work. And non-aspirin, non-steroidal anti-inflammatory medications reduce the risk of multiple system atrophy. They don't do trials of those effectively because you can buy them in the chemist, so no one cares. But they'll keep looking at that. If they can actually change the disease in the animal models, then I think it will become more of a treatment. So again, a neuroimmune potential problem. So I have nothing that is affecting it yet. I think rehabilitation for symptomatic relief is actually probably something that's worth looking at. And there's a whole lot of drugs that are going to come, and I think some of them are likely to be effective. At least they're still in clinical trials, which is great. So, another Dow talk. I'm sorry. Happy to take questions.